Hi, it's David Liew here, covering all the great rheumatoid arthritis material from EULAR 2025 for Rheum Now. This morning we had the second recommendation session. I always find these really fascinating because, especially when it comes to the recommendations, it reflects a little bit about how our thinking changes and really the standards of what we do, how they've changed over the course of time. It's been really interesting because this morning we saw Professor Joseph Smolin present the the latest update on the rheumatoid arthritis treatment recommendations. These have had to be updated every couple of years as things have progressively changed, especially over the last kind of 15 to 20 years as new possibilities and threats come on the horizon. We've had to gradually just iteratively change the advice. And so it's come to be that there's a new update for 2025, and that's updated the 2022 guidance. I just want to run you through a few interesting points from there that are worth talking about. So, firstly, I want to say upfront, um, Justice Smolin was very clear in talking about the evidence behind starting with methotrexate and glucocorticoids rather than starting upfront with a biologic, and showing that there's really no substantive advantage in starting with a biologic. Having said that, there was a bit of an iterative change because previously it had been about there'd been a bit of a question as to what to do after if you had an inadequate response to the first CSD MARD, really methotrexate. And previously had been, depending on your prognostic factors, you might go to a second CSD MARD or you might be suggested to go straight to add on a biologic. That's really kind of shifted away now and, towards going straight through to adding a biologic here in Europe. And really, I think that reflects a lot of different things, including, and this was a name checked in the session, the fact that biosimilars have really kind of changed the emphasis of the way things work here. Affordability of biologics is constantly changing when biosimilars work in the way they should, which is what happens here in Europe. So I think that's really pleasing. There's a little bit in, talking about the other end of that, there's a little bit less of an emphasis in the recommendations about trying to completely taper off and kind of find drug-free remission without any guidance, which I think is was always been something which has seemed a little bit elusive for a lot of patients. So it's really more about continuing, potentially spacing, rather than completely stopping. And that's been emphasized now in the recommendations as well. Once again, reflecting the way people are practicing here in Europe. And then the final thing is that, as always, the JAK inhibitors have been flagged in terms of being a secondary option, really, when it comes to selection, especially after the first agent. And there's still these questions about when we'll get some further determination on safety. Professor Smolin's certainly waiting eagerly to know the results of the baricitinib post-marketing requirement safety study, the oral surveillance equivalent. It's due to report by FDA timelines next year. So I think we're all waiting with bated breath to see what that means in terms of extrapolation of oral surveillance results for in terms of cardiovascular and cancer risk for high cardiovascular risk population, whether the results that we saw for tofacitinib really do apply across all JAK inhibitors. So as much as it sometimes feels that we've got all the solutions for rheumatoid arthritis, A, we're far from that, but B, even the way that we practice with the existing tools that we do have does seem to constantly iterate as time goes on. For plenty more of that, you know where to go. Head on down to rheumnow.com.